So we have completed the topic, that is periarthritis of the shoulder. Next, as far as the rotator cuff disorders are concerned, in order to have a better understanding of that, we have already talked about that suprasubscapularis is something which is located anteriorly. Teres minor and infraspinatus is located posteriorly. But it is supraspinatus which is located superiorly, and it gets impinged in between the head of the humerus. The location of the supraspinatus is such that it will be getting impinged in between the head of the humerus and the acromion process of the scapula. Every time you abduct the shoulder, there is a possibility of impingement of this muscle in between the two fragments, as a result of which it is more likely to get injured. The tear is more likely to happen in supraspinatus, and that is the reason why supraspinatus is the most commonly injured tendon in rotator cuff injuries. All right. By putting a star, you can write down this very important topic, that supraspinatus is most commonly injured rotator cuff. Means most commonly injured component of the rotator cuff. Among all rotator cuff injuries, supraspinatus is something which is most commonly injured. Alright. Now let's have a discussion on subacute tendinitis, also known by the name of painful arc syndrome. Now already you are aware what is painful arc syndrome. It is 60 to 120 degrees of abduction will be painful, and it is because of supraspinatus tendinitis. So it is happening in case of young individuals. The patient will be experiencing more pain when it is held in extension, but when you keep the arm in flexion, the tenderness will be subsided. So anterior shoulder pain after vigorous or unaccustomed activity, example competitive swimming or a weekend of house decorating. These are the things which are going to be mentioned in your question in the form of the etiology. The shoulder looks normal but is acutely tender along the anterior edge of the acromion, as I told you. And this is the key clinical finding, which is the point tenderness is most easily elicited by palpating this spot with the arm held in extension, but when the arm is held in flexion, the tenderness disappears. This is the key clinical finding for this painful arc syndrome or subacute tendinitis. All right. And supraspinatus is the most common tendon to get affected by this subacute tendinitis. And if you go back to the question, you see, if you read the question, the sample question that I provided, the 23-year-old male came to OPD with the complaint of right shoulder pain. Anterior tenderness was present which got relieved with the arm kept in flexion. What is the most probable diagnosis? So answer for this question is painful arc syndrome or subacute tendinitis. All right. Next, rotator cuff disorders like calcific tendinitis, highly unlikely. They are not going to ask you a direct question related to this calcific tendinitis, but it is considered to be a chronic form of tendinitis. All right. So here recurrent attacks of subacute tendinitis, but characteristically the pain is worst at night, and it might obviously lead to a rotator cuff tear. Now, more important is rotator cuff tear. All right. Calcific tendinitis is considered to be a precursor event of a degenerated tear in the rotator cuff. Now, rotator cuff tear, as we have already discussed, the most common tear is seen in supraspinatus. Now, partial thickness which will mimic chronic impingement. That means there will be a pain, there will be impingement, there will be a pain in abduction. So, no such clinical feature which is characteristically guiding us towards the final diagnosis of a partial tear. But in case of a complete tear, there are two very important clinical signs. In case of full thickness tear of supraspinatus, there is a paradox abduction paradox, one of the sign, and a arm drop sign. Now, what is abduction paradox? It is active abduction up to 90 degrees, not possible. But active abduction beyond 90 degrees is possible. This is what we have already discussed about. In case the patient is having a complete tear of supraspinatus tendon, you ask a patient to abduct the lift or lift the arm into abduction, he won't be able to. But when you passively lift it up to 90 degree, then you ask him to lift it further into abduction, he would be able to. That is known as abduction paradox. The reason is, initiation of abduction is the function of supraspinatus, but the continuation of the abduction is the feature of multiple muscles. And most importantly, it is the function of deltoid. So deltoid is active. Deltoid is normally functional. So beyond 90 degree, it would be able to lift the arm. Alright. But up to 90 degree, it won't be able to, because it is primarily a function of supraspinatus, which is completely ruptured. Point number 2, the drop arm sign. Now what you do is, you bring the arm to 90 degree and ask him to hold the arm in this position. He won't be able to. There will be a drop in the arm. Alright. So inability of a patient to hold the arm under 90 degree of abduction is known as drop arm sign. And you know what are the reasons. So it is inability to hold the arm within 90 degrees of abduction. Alright. So this is what is known as drop arm sign. Now, if you go back to the sample question which was being provided, like 53-year-old male came to OPD while such a long age, means elderly age is provided, or a middle-aged individual is provided, because it is a result of a degenerative tear in the supraspinatus. Alright. So 53-year-old male came with the complaint of occasional pain and the weakness in the left shoulder. Asking for abduction, patient was not able to do so, but he was able to bring it into abduction when his arm was passively lifted up to 90 degree. This is what? This is abduction paradox. So what is the most probable diagnosis for this? Answer for this question is that it is the feature of full thickness rotator cuff tear. That is the answer for this question. Alright. So hopefully you are getting a basic understanding of how the questions related to the soft tissue injuries around the shoulder joint are going to be presented. Similarly, now this is the kind of the question which you are teaching with the hope that they are going to ask you one day. And in 2019 NEET PG examination, that means All India examination, they asked this question for the first time. Just by giving you the picture, they have asked that what is the name of the sign. The name of the sign is pop eye sign, and what it is because of. It is because of the rupture of the long head of the biceps. You know, from the coracoid process, there is a rupture of the long head of the biceps. As a result of it, the biceps gets accumulated in the arm. So when you flex the arm, there will be a prominence of this abnormally lying biceps bulk. Alright. So it is because of the rupture of the long head of the biceps tendon. The name of the sign is pop eye sign. So with the flexion of the elbow, there will be a prominence of the small biceps accumulation because of the rupture of the long head of the tendon of the biceps. It gets accumulated in the arm, which will become prominent on the elbow flexion. This is known as pop eye sign, and it is because of this reason. So hopefully you get the reason for the same also. Alright. Next, another, in the form of the question itself, we are trying to teach this topic, because if at all this question is asked, then these are the two findings which will always be kept in your examination. It is, a 22-year-old male came to OPD with the complaint of painful click on lifting the arm above the shoulder height. That means beyond 90 degree of abduction, there will be a painful click and there will be inability to throw. That means an inability to throw with that arm. There was a history of fall on outstretched arm. That means abducted, externally rotated arm. What is the most probable diagnosis? You see, whenever you see the word inability to throw, alright, for example, the patient is a cricket player and he is not able to throw the ball. That means the patient is suffering from a slap lesion, which is superior labrum anterior posterior. This is the full form, superior labrum anterior posterior. Actually, it is the tear in the superior part of the glenoid labrum. Alright, so it is a slap lesion the patient is suffering from. So hopefully you have understood the soft tissue injuries around the shoulder, the basic anatomy of the shoulder. Now we are going to have a discussion on the traumatic events of the shoulder joint. Alright, the first event obviously is the dislocation of the shoulder. A very important topic, that is dislocation of the shoulder, both from the examination point of view as well as practically. Because you know, if you are posted in the emergency, you might have seen a patient with the dislocation of the shoulder in the emergency itself, and how these patients will present to you. This is what the examiner is asking for. Alright. Now, before we talk about the topic, it is important to have a discussion on some sample questions, like a 27-year-old sustained injury to his right shoulder falling from the electric pole due to electric shock. That means a patient sustained the electric shock. He fell from the shoulder, from the electric pole and sustained injury to his shoulder. Now, following which his arm was fixed in adduction and internal rotation. That means his arm was, fixed almost in adduction and internal rotation. That means the patient was not able to lift it into abduction and external rotation. What is the most probable diagnosis for this question? Next, which of the following is incorrect for anterior dislocation of the shoulder? Alright. Next, which of the following lesion on the head of the humerus results in recurrent anterior dislocation of the shoulder? That means which of the following is the lesion due to recurrent anterior dislocation of the shoulder? Alright. So let's have a discussion on dislocation of the shoulder joint. Before we talk about the dislocation or the anterior dislocation in particular, the dislocation of the shoulder can be broadly categorized into three, although there could be a combination of dislocations also, like antero-inferior, posterior-inferior, or posterior, or dead inferior, likewise. But from your point of view, you need to remember the dislocations are of three types. One is anterior, posterior, and inferior. As far as these three dislocations are concerned, the most common one is the anterior dislocation of the shoulder. And this is what we are going to talk about. Alright. So, under the heading of anterior dislocation, point number one, it is the most common type of dislocation. Out of any type of dislocation of the shoulder, it is most common. Now, what is the mechanism? It is, the mechanism you might have read about, that it is a fall on outstretched arm or fall on outstretched hand. Basically, every conscious individual, when is falling, then he will try to protect the centrally lying vital organs by compromising the limb. And how to compromise the limb? By getting an impact on the limb. How to get the impact on the limb? By placement of the limb into abduction and external rotation. So there will be a fall on outstretched arm. That means fall on abducted and externally rotated arm. So this is a key clinical mechanism which is responsible for the fractures in the upper limb. In a conscious individual, the patient will always fall on abducted externally rotated arm. No conscious individual will fall on adducted and internally rotated arm like this. Alright. So this is a natural mechanism, natural phenomena in order to prevent the centrally lying vital organs. So what are the different types? You see, if you look at this normal X-ray, I will just show you the normal X-ray of the shoulder joint. If you look at this here, if the head of the humerus comes just in front of the glenoid, it would be called as preglenoid. If it comes just below the level of the coracoid, it would be called as subcoracoid. And if it lies somewhere not just below the level of coracoid, or neither it is there in the front of a glenoid, it would be called as subclavicular. So basically there are three types of anterior dislocation of the shoulder: subcoracoid, preglenoid, and infraclavicular. Out of these three, the most common one is the subcoracoid variety, because the word common is sharing CO in coracoid as well as common, CO. So the most common type of anterior dislocation of the shoulder is subcoracoid type. Next are the clinical features. Now, this is what is important for you, because every time you are sitting in the emergency, you are seeing a patient coming into the emergency with abnormal position of the limb, with abnormal attitude in which the limb is held, and you have to diagnose clinically itself that whether the patient is suffering from anterior dislocation or not. This is what you are going to learn it. Alright. Now, let's talk about the clinical feature. There will be a loss of deltoid contour. Obviously, if the shoulder joint is dislocated anteriorly, that means head of the humerus is out of the glenoid and is placed anteriorly, the deltoid contour is going to be lost. There will be a flattening over the upper lateral aspect of the arm. That is point number one. Then Dugas test. Now, these are key clinical tests which you can perform in order to identify whether the patient is suffering from anterior dislocation of the shoulder or not. One is Dugas test. What is Dugas test? It is inability to touch